koutou. 90 people joining us this afternoon for a kōrero on telehealth. How exciting is that? I'm going to open up our webinar this afternoon with a karakia, and then we'll go into some introductions of the kaupapa today and the panelists that we have to kōrero about these different things that are happening in our telehealth world. So opening us up with karakia. Manawa mai te mauri noku, manawa mai te mauri rangi, ko te mauri ki au, he mauri te pua, ka pakaru mai te pō, tau mai te mauri, haumi e, hui e, tae ki e. Kia ora koutou, ko Jess Morgan-French tōku ingoa, nō tai tōkaro aho. I'm the current CEO at Collaborative Aotearoa, and it's an absolute privilege to be bringing you this webinar today. From my team is hiding away with her camera off, but has been the convener behind pulling this kaupapa together, and just super large acknowledgements to her and all her hard work in getting us to this point today. We are going to be talking about telehealth. We've all got some kind of touch point or interest in telehealth, and if you're not doing telehealth, it's a great reason to start and also to evolve and do something new. And I think I just wanted to start with a bit of a story. I was in Wellington last week and I bumped into Janine on Tuesday night, and she said to me, "Oh, Jess, I normally work in the clinic on Friday, but I'm down here for GP24, and so instead of cancelling my clinic, I just saw I'm going to just see my patients virtually on Friday." And I thought, you know, what a great example of actually how telehealth can enable us to keep up our education and enable us to go to conferences and do the other things that we need to do within our kaupapa, but not stop the patient contact completely. We can continue to do it all and be able to provide that service. So I just wanted to start off with that little kind of reflection that we had. Hopefully Graham can rejoin or has rejoined and will be joining our panel today. But on our panel, we do have Samantha King, we've got Ruth Large, and we've got Janine Bycroft, and we've got Graham. We are going to open up with a bit of whanaungatanga where you'll get an opportunity to introduce yourselves. But as you do so, we would like you just to start the kōrero around, who are you and what does telehealth look like in your organisation? So it does look a little bit different across your three kaupapa, or four hopefully. So leaning into that question and coming up with some starting points for our kōrero. So I'll start with you, Samantha, then we'll go to you, Ruth, and then Janine, and hopefully by the time Janine's wrapped up, Graham will be ready to jump in. So kia ora.
Thanks, Jess. Hi, everybody. So my name's Dr. Sam King, and I am a medico-legal consultant with Medical Protection. So we are an indemnity provider, and we deal with medico-legal issues for our members, and our members are mostly doctors. My background is general practice, so I do a small clinical component in Papatui in South Auckland. And my background really is I do some telehealth, like everybody else. I do some telehealth in my clinical work, but mostly I'm here, I think, with my medico-legal hat on. And so I really talk about the pitfalls, the things you need to watch out for, etc., etc. And so we do talk to quite a few of our members about telehealth. I think a lot of us are pretty used to it now, you know, having come through COVID. But it's interesting, and in my clinical practice, I have to say I think it's an ongoing learning curve, particularly with GP triage. That's what I found anyway. And so thank you for having me here today.
Sorry, you muted, Jess, but I think that was my turn, right? Kia ora koutou, ko Ruth Large, toku ingoa. So I'm a dual fellowed emergency physician rural hospitalist. So I kind of sneak into the college under the Division of Rural Hospital Medicine, and I'm very pleased to be here. My mother was a GP, so I kind of have a soft spot for general practice. I have been involved in telehealth since 2007. It's kind of a little while ago. Hey, I see Janine nodding. Really that's been principally in the secondary and tertiary care sort of space, building telehealth technology and implementing ways of working. I've got a particular interest in access to healthcare and technology, so I've done some postgraduate study in health informatics. I currently work as the Chief Clinical Officer for Whakarangara Aotearoa, which supplies Healthline, Quitline, 1737, bowel cervical screening, those sorts of things. And I found myself there about 3 years ago, really on a background of an interest in access to healthcare. In terms of my telehealth clinical practice, up until recently, we had doctors within telehealth, within Healthline, and I was working in that space clinically. But at the moment, I'm mostly clinically working at Middlemore Hospital in person.
Called Janine Bycroft, aho. Lovely to meet you all. I'm Janine Bycroft, and firstly, apologies. I'm at the tail end of a upper respiratory tract infection and don't normally sound like this, so I won't be talking quite as much as I keep sipping to try and keep talking. Look, I'm really passionate around telehealth and just see lots of opportunities, but it's not the be-all and end-all. It's an add-on to what we do and sort of the hybrid model as we're talking about. It has its place, but obviously there's still real value in that in-person care. So I have an interest both from working in general practice in Mount Wellington and also in Auckland, and work as an associate clinical director at ProCare. So I've been involved with Collaborative Aotearoa and other in the GP College when we helped develop some modules around telehealth over COVID. And then also as the CEO for Health Navigator Charitable Trust, really focused on the whānau and consumer perspective of telehealth and what that can look like. So for the Health Play website, we have a number of resources in that space. So kia ora, back to you, Jess.
Kia ora. And hopefully Graham comes back. Graham is the medical director at Tend, which is one of New Zealand's largest telehealth providers, supporting patients from lots of different regions now. I don't want to say how many because I feel like they keep growing in different directions, but started in Auckland and have built a model of care within the general practice that is founded on telehealth and providing alternatives to in-person consultations as an add-on, but not as an instead of. So do have the kind of hybrid model that sits across that space too. And just I think a really good message to kind of found our kōrero today is it is an and there's always going to be the need for the in-person care and that connection and contact, and then there's also the time and place for a virtual connect and contact. So it is I guess finding that balance between the two different services that we provide in general practice. Nee and I have just spent the morning with a whole lot of practices from Northland who have been a part of the healthcare home model of care, and telehealth and telephone triage and telehealth appointments have been a really big part of the healthcare home model of care. And what we heard for the first 45 minutes was practices telling us how they couldn't live without phone triage, and how, you know, bringing in telehealth alternatives, portals into their practices has been absolutely game changing. It's supporting them to support their population. So reassuring way to start our kaupapa. And, you know, right on cue, Graham's here to introduce himself and tell us a little bit about what telehealth means for your kaupapa.
Can you hear me, team?
We can.
And can you see me now?
Yeah, we can.
Oh, congratulations. Fantastic. So it's a great way to start a telehealth webinar, isn't it? My apologies, everyone. Having some technical issues. Tēnā koutou katoa, ko Graham Dena tōku ingoa, he GP aho, ko aho te Chief Medical Officer at Tend. So I'm the Medical Officer at Tend Health. Tend's been around for about 4 years, and we're building a national primary healthcare network of GP clinics, but supported by smart technology and greater clinical processes and operations, of which telehealth is obviously a key part. So video consultations is a key part. So we're not a telehealth company, but telehealth and video consultations is just really built in as a standard care delivery option as part of our services. So in the last 4 years, we've done many thousands of video consultations. What that looks like practically for our patients is they can, so our enrolled patients, of which we have about 130,000 across the network now, they can choose to book video or in-clinic consultations with their, their usual primary healthcare team. But we also operate a national video consultation service, which is more focused on same-day care. So that's really aimed more at improving access and lifting acute demand off of our GP services and the health system more broadly. So yeah, that's what we're up to at Tend.
Kia ora, Graham. Thank you for that, and thank you for that summary. Probably a little bit more detailed than what I offered before you jumped back online. So great to have that detail. And how many practices currently has Tend got across Aotearoa?
So we've got 25, but of those, I mean, we've got an ongoing process of integrating them sort of fully onto our technology platform. So, so at the moment we have 9, soon to be 11 practices that are sort of fully integrated, which means patients use our app as the portal, which contains the software for video consultations, and those practices adopting the clinical operational processes and governance that goes along with that. And we'll just be chipping away at that over the next year or two until we've got all of those practices fully integrated.
Kia ora. Change processes, so important, right? When introducing new things into general practice or into any organisation, going through that correct change process and enabling everybody to come on a journey. I spoke to a GP yesterday and we talked about model of care kind of redesign within their practice, and I said to him, do you know what, we could rock up on Friday with the model of care that we're probably going to come out, the result will probably be the same, but we've got to go in and let your team design the model of care. We've got to get people on that journey and get them ready to deliver, because if there's buy-in from that practice team, we're more likely to be able to achieve the outcomes. Do I believe that the outcome of that model of care will be much different to the one that we could probably put on a piece of paper tomorrow? No, but we will get 100% better buy-in by bringing all of that practice team on that journey and that process. And I think that's something that needs to happen in the telehealth and virtual health space as well. It's a change. It's doing things differently and enabling our teams to be on that journey. The first question is for you, Graham, and it is around what tips and tricks have you found work successfully and sustainably with integrating telehealth into your general practice workflows?
Thanks, Jess. Yeah, and I think, I mean, the sustainable piece of that question is probably one of the most important pieces. I recognise it's a little different for us at Tend. We're very fortunate position where we've had the opportunity to really develop technology in parallel in consultation with our clinicians and our operation teams that just allows us to more deeply integrate that into our general practice workflows, which includes the operational processes and the clinical governance to support their safe use. And realize that's a much more challenging proposition if you're operating in a small practice with only four partners. But I think the same principles apply. I mean, my experience of using telehealth tools outside of Tend and the feedback that I've had from colleagues is that integrating telehealth so that it is sustainable and effective is, to use a Gen Z term, luggage. Most GPs that I've met, for example, who tried DoxyMe and those kinds of tools during COVID have ended up going back to using phone consults because using those tools just wasn't a good patient or clinician experience, and they're clunky and the technology just gets in the way of working efficiently and smoothly, which is obviously super essential in such a time constrained environment as general practice. So any advantages of working with video were just outweighed by the impacts on efficiency. So the first thing in terms of being successful and sustainably integrating it is really making sure that whatever the technology is that you're using is reliable. It's simple to use. Ideally so simple that you really don't need to do much in the way of training for clinicians, and that it just doesn't get in the way. And I think that's why we see that, a significant proportion of general practice has reverted to and just back to in-clinic care, or for that matter, if they are continuing to do telehealth, that they're using the phone, just because the technology doesn't get in the way. If you're going to move into using other forms of telehealth, video, etc., whatever you do, you just need to spend the time to make sure that it works really efficiently within your normal workflows, and so that it just doesn't get in the way. The other key thing I would say is really not so much around the technology, but it's more around the clinical processes that you put in front of the telehealth components, to make sure that the right presentations are getting into the right mode of care. Because if you see a patient in a telehealth consult who then requires a physical examination in order for you to solve their problem, that's a second appointment effectively, which isn't a great patient experience, but it's also actually a terrible use of health resources and of GP and or nursing time. So and you're doubling the amount of clinician time, so that has access implications and cost implications. We have put quite a lot of effort into that problem. It's actually quite a hard problem to solve, but you need some sort of process integrated into your clinical workflow that effectively triages people into the right mode of care. If as far as possible, I think it's impossible to get that completely right every time. So you clearly need processes in place that provide options for redirecting people into in-clinic, in-person care if needed, but the less you have to do that, the better, obviously. That said, our experience over the last few years is that patients are generally pretty good at choosing the right mode of care. We've got good data that correlates, patient presentations with sort of clinical coding, and most patients are pretty good at making good choices, not all. Where that falls down, though, is where there's big differences in accessibility between telehealth and in-person care, because a patient's desire to, and or desperation, as the case may be, to seek care will trump them making the right choice. And so, quite often in the telehealth context, I'll see patients who will upfront will say, look, I know I probably should have come into clinic for this, but I couldn't get in for 3 weeks. So here I am. But I think a key thing there is then, I talk to our clinicians about working in sort of 2 different modes in the telehealth when they're doing video consultations. One is, this is a problem I can safely solve and resolve. But if not, there is still a real value. It becomes more of a health navigation role, which is directing people into the appropriate mode of care, perhaps providing some temporizing treatment if you can do that safely, doing good safety netting, all those sorts of things. And then lastly, I would just say it's also making sure that you have good data and good reporting, good clinical governance around your services, so that they actually guide the development of your services. I'm a big believer that telehealth, I've said this to Ruth before, I think actually, I'm looking forward to the day when we stop talking about telehealth, really, because it's just a mode of care, and it should be a routine mode of care. It's not a replacement for in-clinic care, obviously, but it is an important adjunct. But you do need to make sure you've got good data, good process, good reporting around it, so that you can actually understand whether you're being effective, whether you're being safe, because it obviously, I think, and you need to put that around each mode of care that you deliver. Yeah, so those are my thoughts on that question.
Kia ora, Graham. I feel like you answered all of the questions in the slide deck in that one statement. So I'm just going to encourage the 113 people online to go into the Q&A and help me out with a few extra questions that we might be able to throw to the audience, or sorry, to the panelists from the audience, because yeah, you did. I was sitting there going, oh, yeah, there's the answer. But anyway, we will see what the other panelists have to say about some of the things. And always go a little bit rogue on these things and don't follow script just to keep you on your toes slightly. Janine, we'll go to you next because I think Graham touched on it, and I think that you can kind of take your worldview into that space. The question is, can you describe the most no, that's not the question. The question is, how do you support patients to know which mode of health they need to get to? How do you support your team or support your reception staff or the people booking the appointments to make sure they get the most adequate model of care, like whether it is coming into the practice or whether they are really suitable for that virtual care?
Yeah, kia ora. Look, yes, obviously if they book through the portal, the easy option, well, a good option is to have some guidance for them so that as they come to book, you can have some criteria around these are things that we can often manage through a video telehealth consult, and these are things that you really need to come in for. So you can have that list, and look, there are lists. The GP College has got a list and a guidance. The Club Te Aotearoa have got a toolkit, and we'll put the links in the notes for you. I've got those, I'll add those shortly. And so that can give people just that clear key info, which is really helpful to have up front. Obviously, you can say things like if you've got chest pain, if you've got significant shortness of breath, if you've got severe abdominal pain, you need to get seen in person. So you can have that guidance for people. You can also give that guidance to your reception team and to your nursing team so that when they're triaging calls, everyone's on the same page around what are the things we as a practice are comfortable to see via telehealth versus in person. And there's been so much work over COVID where there's some pretty good consensus around what are those things that can be sort of usually managed safely by a video consult. You can also raise people's expectations around the fact that there will be times that they will need to come for in-person consult, and so that they're aware that, look, actually that is something that will often maybe needed at times. But as you say, Graham, sometimes you can at least do that navigating and that guidance and put in place some initial things. So it might be if someone's presenting with long-term chronic abdominal pain, it might be that you can organise some blood tests and a few things first, and then you can arrange to see them for a follow-up consult once some of that initial investigations would have been done, even if they'd been seen in person. So yeah, that can work quite well. I mean, you can even deal with ear infections, sore throats, urinary tract infections, colds and flus with teleconsults, and a lot of skin conditions. So that's often something that can be done quite well. You can even, depending on what platform you use, you can even take a photo or even a little video with some of these platforms so you can capture it directly into the notes. So that can actually be a real advantage. At the moment, we still have a bit of a clunky workaround to get photos into the PMS at our end, which I would love to see resolved, because it is something extra that you're doing later to make sure it gets into the right notes. Then obviously some of the other things would be if someone's got severe mental health or severe vomiting, severe headaches, those sorts of things, they would need to be seen in person. But I think having that clear guidance through the booking system, either through reception or if they're booking online, is a really great way to start. And also encouraging people to think about the technology. So having a wee guidance document about what can they do to check their video, to check their audio, to make sure that that is all enabled so that you don't lose time at the beginning trying to get cameras or audio working. So yeah, and as you say, Graham, using platforms that are really simple and easy. A lot of our priority populations are familiar with using FaceTime or things like that. So while I don't recommend FaceTime for telehealth consults, they're used to using video for these things. So yeah, keeping that as simple as possible. One of the things I have found is when I have been doing phone consults, which I really try to avoid, I much prefer to do video telehealth. Trying to get them to move to video can be a bit trickier. And so having a URL for whatever platform you're using that's really easy is much easier. Mine is Dr. Janine, so Dr. Janine, but even that is hard sometimes to explain to people, particularly if English isn't their first language. So I have intended to change it just to a really simple number to make it easier to give people that. So yeah, having those different things can be helpful.
Kia ora. What a great summary. And I think, yeah, some really good learnings in there for us all to take away. I think one of the things that we need to be doing more in general practice is offering that telehealth appointment. I think so many times we're just so in the gemba and we're in the gut mode of just booking the appointment and not really taking those steps that Janine talked about to go, is this the best mode of consultation for this patient? And I come to that because I was on a call this morning where a GP was supervising a PGY2 and he said to the PGY2, what is the first thing that you open your consultations with? And the PGY2 responds and says, sorry for making you wait. And I just go, if that's not compelling, and if that doesn't make you want to change the way you're working within your practice to provide care that is patient-centered, I don't know what will. But I thought it was really interesting that that was what he responded to with that question, and something for us to kind of just sit with as we navigate through these brilliant people online who have come into Save and Bacon with some questions. So we'll flick to the Q&A questions for a bit. They're pretty quick fire. And then we'll come back to my scripted ones. What PMS is the most effective for integrating telehealth? Should we just do a quick fire around the screen? What are you using, Janine?
Look, we're using DoxyMe for our virtual, for our video telehealth. It's not necessarily the best option, but we're on MedTech 32, so we don't have anything integrated. Yeah,
cool. And you'll be migrating, because I heard that they did put a sunset date in that they said that they weren't going to do. So that's exciting for the telehealth world. Graham, what are you guys using at Tend?
Yeah, I mean, I don't, unfortunately, that this is one of the problems which I alluded to, which is I just don't think there is a good there's not a great third-party option out there. The simplest options, as you say, tend to be things like Facebook or WhatsApp, but they, then we start running into data privacy issues and so on. So, we have a platform that has been, we've effectively built our own. So that's not a very satisfactory answer for general practice more broadly, unfortunately. But yeah, it is challenging, and I don't unfortunately have a good answer for that question.
Did yours feed into Indice or MedTech?
MedTech. So we use our patient record as indices. So we actually have a single instance across the whole group. So all of our patients are in the same bucket. So it doesn't sort of matter where they're seen across the motu, which is great. And also that's great from a data perspective. But our video consulting platform is sort of increasingly deeply integrated with Indice over time.
Awesome. And what equipment do patients need to access their telehealth appointment, Ruth? Do they need a phone, computer, tablet?
Well, I mean, ideally, the patient will use whatever device they've got available to them, right? I mean, the trouble with mobile phones are pros and cons. If you want to get someone to see their tonsils, they're brilliant because it's just like swallow the phone for me, and you get really great, pictures that way. But you also get the wobbles. So I think it's not really our call to dictate what the patient should be seen by, but you do need to be aware of the different foibles of what they might be on. And mobile devices, mobile phones can be challenging, but let's face it, the majority of people, that's what they're doing their consults on.
Cool. Kia ora, Ruth. Sam, you might be able to answer this one. How do you best support whānau with low digital/device literacy? For example, elderly whānau who live alone, or it's their first time accessing services in this way. And what are some of the successful strategies you've, executed to make that happen?
Yeah, so generally speaking, you need to rely on their family, their whānau, to teach them how to use the platform. And most of my consults on video, which is obviously my preference over telephone, is done on a mobile. And it's surprising actually how many older people are reasonably au fait with how to use a phone. So I think in general, so long as whānau set them up, show them which button to push, and off you go. It actually works really well. Yeah.
Awesome. And I think this is Kuroria who asked the question, and you're from the Hokianga. And the last time I was in the Hokianga, they had the little, is it Dora? The tech bus that goes around helping people to get on to digital technology. So I think it's about leaning into what's in your communities too, right? And offered in different spaces. It was really interesting because there were some people in the space that were, I'm off to Dora to go and figure out how to use their devices for different things. So yeah, leaning into that space. Vicky's got a question for you, Graham. What percentage of 10 consultations are done or delivered by telehealth?
Thanks for the question. Yeah, it depends a little bit how you count. So obviously in our Online Now service, that's an entirely video based sort of low acuity same day net. So that's all video. But from within our booked GP services, it depends a little bit on the location, unsurprisingly, of the clinic, of the sort of home clinic and the demographic of that clinic. But it sits roughly around the 40 to 50% video versus in clinic. So in clinic actually still dominates currently. I do think there is potential for that to move further. There is a lot of part of this is patient retraining as well. Patients are just used to engaging with primary care in the mode of, oh, I need to book an appointment in 2 weeks' time with my GP and sit in front of them for 15 minutes in clinic. Some patients prefer to do that. That's absolutely fine, of course, as well. So I think it's really important that we don't throw the baby out with the bathwater. And patients that have choice in the way that they engage with us. But yeah, so currently it's sort of sitting around the 50% mark.
Nice, awesome, thank you. And there's a few other questions that my panelists are quite efficiently answering by themselves in the Q&A, so that's great. We'll go back to some of these scripted questions. The next one's for you, Ruth, and it's around training our general practice team members to be really good at telehealth. And when I think about this, I kind of giggle a little bit because we've all got that experience of a GP in our practice that's like, I'm not doing that, or I'm not doing that telehealth thing, that's for the young bucks coming in. So yeah, how do we get everybody comfortable and confident? How do we give them the skills that they need to be able to effectively deliver telehealth?
Yeah, and excuse the gum, I've got a blocked ear. So I think it's, I would start by saying there's nothing wrong with not doing telehealth. And I think for people who really, it's not their vibe. It's not their vibe, and that's 100% fine, because actually we need people to be seeing people in person. So I think there's particularly depending on your risk aversion or not, and I'm sure Sam's going to talk more about this. Telehealth may just not be those particular people's thing, and there's no point in forcing people into those pathways. The GP College has got some great material there doing good telehealth consultations, and we're really talking mostly, I think, by video, but there's also tips and tricks for phone. There's some great webinars that you'll find on www.telehealth.org.nz and on health literacy and telehealth. Things like setting up your your videos and those sorts of things, and asking questions, things, tips and tricks about physical and mental health examinations. I think almost part of the problem is that there's a huge amount of information out there. And one of the things that I would say makes the most impact is having a peer group that you can discuss and practice with. So we ran a 2-day workshop recently, and with the collaborative, as you know, and Sam and Janine came and talked at that workshop. That was really valuable, but also what was really valuable is actually having some practice patients. And what we got out of those practice patients is we got them to feed back to the clinician how they found that consult. And I think that was actually really invaluable. So we'll run some more of those. But I would just say take up every opportunity. And I think Graham Jelly's on the in the audience, I think, and he chairs the community of practice for the Telehealth Forum. So hit him up as well.
Kia ora, Ruth.
I was
jump in, Graham.
I was just going to echo Ruth's comments there. I think about absolutely not forcing people, but also the two things I would say. One is challenging assumptions. One of the things I hear regularly from GPs is my patients don't want telehealth. I think often that translates into I'm not comfortable rather than my patients don't want it. And the other thing is going back to what I said at the start, which is just as making it frictionless, as frictionless as possible, because we're all absolutely under the pump as GPs. I mean, I have GPs raging because we add a process that requires 2 more mouse clicks, let alone having to deal with a whole new technology. So, motivating GPs to sort of have to take on this whole new thing is, understandably, you get a lot of resistance to that. So you just got to really focus on making it as easy as possible. And obviously it's got to feel safe.
Can I just pick up that point that Ruth made about some doctors are a little more risk averse than others? And, because I have that medico legal hat on, you get some who probably are a little bit too gung-ho, quite prepared to take shortcuts and take risks. And that's the thing about telehealth. Often we're in this mode of this is only a virtual consultation. It's different from an in-person. But the reality is we're held to the same standard by our council. So you've got those slightly more gung-ho, she'll be right. And then you've got the others who are very risk averse. And I think, if you can get some training to which is what Ruth is doing. That was such a good training 2 days that they had. Well, the group were fantastic. And I think if you can get some training, I think those people who are risk averse will feel more comfortable. And I think those who are a little perhaps too gung-ho will perhaps think about how they might practice a little more safely. And I think if we can, we peer review a lot of times, primary care, we're all part of a peer review group. And if we could do that and run our consults through our peer review group, we might all learn from one another, because GPs generally are very siloed. We all work in our room with our own patients and no one generally gets to have a look in on that, not unless we're in big trouble. So just a thought.
I think it's really good, Sam, and I think it kind of leads a little bit into our next question, so that's helpful, which is around what are the critical components of a telehealth policy that should be included to align with current regulations and legislations. And I think, some of our practices love the word policy, but most of them kind of get a little bit shaky when that word comes around. But it is something that safeguards us as people working in general practice to be able to deliver the services that we need to deliver. Nii and I went into a practice who were at the other end of really risk adverse, not wanting to, actually scared of doing telehealth appointments because of the medical legal risks. So I think it's about everybody on that journey and about trying to support. But I think a policy is one way that you can provide some safeguards, some guardrails, some frameworks to be able to keep your practice and your practice team safe. And what are your thoughts, Sam, around what needs to be included in that space?
Yeah, there's actually quite a lot, I think, that could be included in a policy. So these are just the things that I've noted down. So first one is about an appropriate selection of patients. And so one of the things, for example, is, do you allow 18-month-old to have a telehealth consult? And I would, depending on your patient population and their health literacy, is that something you want to do? And especially if you're doing it by phone, makes a huge difference if you cannot see the patient. And I've had plenty of patients where you talk to the parent and you think, oh my gosh, this patient needs, this 2-year-old needs seeing, and they come into the clinic, happened to me last week, and they're running around the clinic and you just can't tell. So it's about, patient selection, and is your practice going to set a no to, under 2 is going to be seen, or whatever you might set in terms of expectations. I think you need to put something around the principles of when you should choose to convert that into an in-person consult. And you can refer people in your policy to the resources that Janine has mentioned. So you don't have to have an extra detailed policy, but I think you should refer people so that they are trained to know, oh yeah, these things probably shouldn't be seen by video. Having protocols and templates. As I said before, if you're taking shortcuts because it's only a video or only a phone consultation, having a template is really helpful so that people have got things to follow and say, oh yeah, I need to ask about this, this, and this. I think it's important to ensure that doctors or nurses are following good practice in terms of clinical notes. And I assume that most practices would have a separate policy around clinical notes anyway. So clinical notes are really important and should be standardised. Medical certificates, a lot of people will ring and all they want is a med cert. And we think, oh yeah, it's only a med cert, so we'll just flick that one off. But there are certain things that you need to think about. And the Medical Council have got some excellent statements around that, and we are measured by those statements. So I do suggest that you refer your clinicians to those statements so that med certs are really accurate. Lots of employers now are writing to the Medical Council to say that a clinician has written an inappropriate medical certificate. So just a little warning bell there. Medical Council also have good prescribing statement, and that's really worth looking at. It's about when can you just do a quick repeat prescription, or when should they be reviewed, all of those sorts of things. Because obviously for most of us, because of the workload, we want to, oh yeah, it's a repeat prescription, we'll send that to them without too much thought. But the reality is any prescription we sign, we are responsible for. So you need to think about that, and Council have some things to say about repeat prescribing that's worth looking at. If you are doing telehealth for patients overseas, and I don't know whether 10 are doing any of that actually, but if you have got patients overseas, obviously you have to be registered in New Zealand with our council, but you do need to also find out if you need to be registered with their council where the patient is. So that does bear looking into. It's quite important. And probably need to think about your indemnifier and whether you're covered for that kind of thing. That's something small. I don't know how many practices actually do that kind of thing. And probably lastly, consider continuity of care with your patients. And, for all of us, because we work in teams, it's common to have patients who just see anybody in the practice. And that's no different with telehealth. And it's really around communication with their regular GP. Big part of that's your clinical notes, and just ensuring that the patient is at the centre of the consult so that whatever's happening with them, they don't fall through the cracks. So those are probably some pretty broad areas I'd include.
Kia ora, Sam. We'll go to you, Ruth, and then to Graham.
Actually, I've got a supplementary question for Sam, which is really sort of relating to policy and when something shouldn't be seen by telehealth. And I know that I had this sort of knee-jerk reaction a little bit when I worked with the collaborative, actually, when we did our first lot of guidelines on what could or should be seen by telehealth. And there was this like, don't see chest pain on telehealth. And I'm like, hold on a minute. There's always if you can always start a consultation by telehealth. And that's always been my argument. You always start, but you need to know when to stop and defer and turn it into an in-person consult and where that person could go. And I wonder, in terms of policies, whether if we say this shouldn't be seen, that could get us into trouble when we do see that person. Do you know what I mean? And somebody, you know, something, and things go wrong, right? Or but they're not necessarily because of the telehealth consult or whatever. But there might be this immediate, you know, your policy said that you should not see that by telehealth. So I'm interested in your thoughts around that. Sorry, Jess.
Yeah, no, that's a really good question, Ruth, because the more definitive you are, the less like a policy it is, because policies generally are broader. But you're right, that if there was an HTC complaint, the HTC would say, well, your practice policy said this and you've breached it. So I think as clinicians, we make clinical decisions all the time, and so everything is based on your clinical judgment, and every case is different. And, you know, if you don't have a lot of, if the patients aren't very good at self-selecting, and I was really interested to hear, Graham, that your patients seem to be quite good at choosing those, I would have to say that probably I don't find that so much in our practice. But if they're not very good at choosing, it's absolutely the right thing to do is to take as much history as you can, work out where do they need to go. Do they need to hang up and call 111? Or, you know, can they wait for a couple of hours while they're seen, or do they need to go to an A&M clinic? All of those sorts of things. So yeah, policies should be general, but if in your practice, you know, you think, given you know your staff, you think actually no, there need to be some hard rules around that for patient safety, I think you should put them in. So it's no one size fits all. You've got to tailor it to your particular practice and your staff.
Kia ora. We'll go to you, Graham.
Thank you, Jess. Yes, so look, very, very much in line actually with what Sam and Ruth have said. So I think the reflex is to say, well, we shouldn't see any kids under this age, you know, in the telehealth context. I mean, I think that there are broad rules that you can come up with that, you know, that make sense from a risk perspective. And so, you know, I think very young kids and infants is one. But, you know, that said, it might be a mum with a perfectly well infant with a mucky eye who's wanting some advice about conjunctivitis. So it's very hard to make clear, you know, lists of things that should and shouldn't be seen. And I think actually that's the wrong approach. It's more about having, as you say, broad principles, and also just building good mental models for your clinicians about how to approach telehealth consultations, because it's so highly dependent on, you know, on the patient, the nature of the problem, the quality of the history, the experience and confidence of the clinician involved, and that just makes it very, very hard to be prescriptive. The way I describe it to our clinicians sometimes is, you know, any consultation, whether it's telehealth or otherwise, is this process of information gathering that gets you to hopefully a threshold where you feel like you can make some sensible clinical decisions, you know, safe clinical decisions around treatment, and you either reach that threshold or you don't. And that is exactly the same in the telehealth consult as it is in clinic, really. I mean, you have less tools available to you, but in terms of that process of information gathering, you either get to that place where you think I can make a safe decision here, or you don't. And that's going to be very individual depending on all of those factors I described. So I think broad policies and maybe some clear rules around very high risk areas that's the approach we take anyway. In answer to your question too, Sam, just around overseas consultations. So we do have a policy around it. We don't do it generally, but we also don't have a practical way of preventing our patients who are have the app from not using it if they go away on holiday and so on. So we do get the odd one. I guess that might increase over time. Our approach currently is, you know, provide some general advice, but always refer the person to local, you know, to local healthcare, irrespective of where they are, really. That's the short answer.
Kia ora. Thank you, team. That was a good little segue and a little fluster of questions in there. Graham, I'm going to bring your attention to a question, and the other panelists as well. There's a question in the chat around the financial implications of bringing telehealth into the practice and whether that creates more patient debt and how that works. If you guys could diligently use the Q&A function to answer that question, I think it's one that many practices have when they start thinking about bringing these services into the practice. And also just want to kind of highlight that Collaborative Aotearoa have just done a whole new financial modelling tool which enables you to look at how bringing these services into your practice might have financial implications, maybe pro, maybe better, could be break even, or it could be a little bit to the other direction, depending on how that implementation of change works. So if you'd like a copy of that, just email admin@colab.org.nz and we can get you a copy of that financial modelling spreadsheet. Really good for practices that are wanting to think about maybe introducing phone triage or different services that aren't normally chargeable to the patient in that space. You guys have been such an engaged audience with some really good questions. So just wanted to do a bit of a shout out to you all in that space. We're going to do a final wrap up question. You've got about 60 seconds each to answer the question, and then we'll wrap up with a karakia and close out for the day. The question is around privacy and security. So how do you ensure the security and privacy of patient data? I guess that leans into Māori data sovereignty during telehealth consultations. So we'll start with you, Sam, go to Janine, go to Graham, and then finish with Ruth.
Yeah, look, I'm not into tech at all, but you obviously need to make sure that the platform you're using is secure and fully encrypted end to end, all that kind of stuff, which I'm sure Graham would be able to speak into. But a lot of it's around informed consent, and patients need to be aware of if anyone's in the room with you, all of those sorts of things. Are they comfortable with it? And so long as they know what is happening and what is happening with the information that is gained. Patients might think you're recording the whole consultation, which I don't think any of us do, but it's all about informed consent. So the more information you can give them, the more they're able to make a sensible decision for themselves.
Kia ora.
Yeah, look, really good points. And I would add, where possible, have some of that set up ahead of time so that people can read some standard guidance before they come into the consult, because spending lots of time getting informed consent at the beginning is really time consuming. One of the things I would say is that don't use a background like I've got. People actually would prefer to see the room so that they know that you're in a closed room, the door's closed, there's not obviously other people around you. And as you say, Sam, that you explain the privacy and so forth. In terms of the tech and privacy security, I'll leave that to the others. But just a heads up, I have put quite a few links in the chat. I created a question called resources, and there is an online telehealth training course that is free for anyone to do through Learn Online. So that link is there, and that would be a great one to encourage all of your staff to do as a starting point, and then to look at more particular training, and as you say, that peer group as people start to use a little bit more, and help them with the tech so that they're not struggling around the audio and the all of that. Have someone come and just help get their screens set up things, but that diverts a little bit from the security privacy. Over to you. Thanks.
Thanks, Janine. So the technical piece, it was interesting. This actually came up. So I was in a session with Samantha at the college conference on the weekend, talking about the use of AI and general practice and healthcare, and similar. I've forgotten your colleague's name, Samantha, who talked to this point around actually effectively, I think, from the technology perspective, you need to do a PIA on the technology that you're using. So a privacy impact assessment, you need to actually, and that sounds highly technical, but it's not actually that complicated to look at, the digital privacy, data privacy aspects of any tool that you're looking to use, or you, I guess, want to see that has been done by a trustworthy third-party organisation. And satisfy yourself that way. And then, the other points I would just echo around informed consent. And there's a few little traps around telehealth there, things that you may not necessarily think of. A classic one that's already been mentioned is just the limited field of view which doesn't necessarily tell the patient who else might be in the room with you, or vice versa.
So 2 seconds worth of my opinion, which is that I agree with everybody else's opinion. But I would also say that the MPS does a great podcast. And there's a really interesting, great one on AI, Sam, and I think we've talked about doing one on, or you've talked about doing one on telehealth, right? So I think, technology is here. If you don't feel expert in it, make sure you consult someone who is, because there are little traps in there, and you just need someone in your practice who's got your back.
Awesome. Thanks, Ruth. And thanks to our panelists. What awesome advice you've shared with our community today. It's been awesome to, kōrero about it, raise some of those crunchy questions, talk through some of the challenges that we've got within the sector on telehealth, but just generally have that kōrero and that conversation. And hopefully, if one person out of, I think at one point we had 115 people online, one person starts doing a little bit of telehealth, I think we've won for the day. So little bits, small bites, get your way there, and ask your community for awhi and support. Collaborative Aotearoa have a full digital health work stream. Ni is available to you at any time if you would like to connect with her and figure out what's going on for you, what's the best technology for you to use, workshop and do any of that with her. She would love to probably spend more of her day doing that. So feel free to get in touch with her. We can send out her details after the hui today. Otherwise, you can get in touch with her at admin@colab.org.nz. And so, keep us in mind. We're here as a resource to awhi. We do have some modules which are currently on Learn Online. We are going to bring them over to a slightly user-friendly technology to make them a bit more accessible. And we're also working up a few more modules that are a bit more specific to our rural communities. And we're also looking at one that will be a little bit more specific for our kaupapa Māori practices, which look at different elements that you might want to consider when introducing telehealth into your practice. Thank you for all the questions and being a highly engaged audience. That's been really awesome. I'm going to close us out with karakia and wishing you all a fabulous Wednesday. Kia tau, kia tātou katoa, te atawhai o te tātou ariki a ihu karaite, me te aroha o te atua, me te whiwhina tahitanga ki te wairoa tapu, ake, 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 āmene. Ka ki te koutou, kia pai tō rā.